Welcome everybody to our last official meeting for the semester. We're very pleased to have Dr. Courtin here from the UK. And as you can see from the slide, she'll be discussing something that a lot of our group members are excited about, which is essentially cohort change in the relationships between genetic risks and an outcome. In this case, it's cognitive decline. I didn't ask beforehand, would you like only clarifying questions first, or would you like to have Q&A throughout?
I think clarification questions would be great throughout, and maybe we keep the more substantial comments for the end, if that's okay.
Perfect. Thank you very much for that. And when you're ready, please go ahead.
Great. Thank you so much. And thank you very much for having me and for the invitation. I've been following the work of your group for a while now, so I'm very excited to get to meet you, even if it's just over Zoom. And I wanted to start with an apology. I'm really sorry I had to cancel about a month ago when I was due to present. COVID caught up with us, and we all got really sick with no childcare, so it was not the ideal moment for me to present. So I really appreciate your flexibility and you inviting me again a month later when we are back in good health. So thank you for that. So I'm gonna present work on the changing association between genetic risk and cognitive decline over time, an observational study in the United States and England. This is work that I am doing with a number of great co-authors, and I think you are familiar with at least some of them in your group. So this is work done with Robert Greener, with data scientist and statistician based at the same institution as I am, the London School of Hygiene and Tropical Medicine here in London. Jordan Weiss, who is a research scientist at Stanford. Erin Ware, who knows everything there is to know about genetics and cognition, and she's based at University of Michigan. Jennifer Dowd at the University of Oxford, who is a demographer and population scientist, and David Rakoff, a social epidemiologist at Stanford University. So they're a great team of co-authors to work with. It's been a pleasure to work with them through the challenges, as you would see, of working on this on this paper. And this is work that is funded by the UK Medical Research Council for Skills Development Fellowship. Sorry, if I do it like that, yeah, that works better. So this is the quick overview of what I'm going to present today. I'm going to spend a bit of time on the background and rationale for the study, largely because this is really, for me, stepping aside from what I usually do. Most of my work, as I will mention in a second, is on the effect of social policies on health. So this line of work is a bit different from what I usually do. So I'll tell you a bit about how we came about working on this, and the literature that drove us to work on this topic, the data we used, so the health and retirement study and the English longitudinal study of aging, the methods, our key findings, a discussion, many of the challenges that we encountered and the questions that we are not sure how to answer yet, and future work in this area, which I hope echoes some of the work that you and in your group, you're all doing. So let me start with the background and rationale then. So as I just mentioned, most of my work is on trying to assess the effect of social policies, so non-medical policies like education and income policy, on a range of health outcomes. I have a background in social policy evaluation and social epidemiology. And when I was still in the US for my postdoc, I got funding to come back to the UK by the UK Medical Research Council. They have a skills development fellowship, which is, I think, very similar in scope and ambition to a KO1, in the sense that there's a piece of research that you're doing, but also quite a lot of money spent on training, mentoring for you to explore a new area of research. So my goal for this fellowship is to look at the heterogeneous effects of social policies on health outcomes in two ways. expanding basically my research to new data. So the first part is using administrative data and machine learning in randomized controlled trials of social interventions, but most relevant for this talk, trying to use genetic data using gene by environment interactions and leveraging all the work I've been doing on quasi-experimental evaluation of schooling, education reform, and trying to combine that with genetic data in a number of data sets, mainly in Europe. So, and as I said, all that work focuses on experimental and quasi-experimental approaches in terms of methods. So before I went back to the UK, I was fortunate to attend this summer school, the Genomics for Social Scientists summer school, which is really fantastic. I'm sure many of you have either attended or presented at its summer school, and that's how I met Erin, and David Rakoff was also attending. We're already working a bit together. And I mentioned to him my interest for this fellowship I was going to start on education and cognition, and how intrigued I was about recent trends in dementia incidence. So I will come back to that in a second. How dementia incidence seems to be decreasing in a number of high-income countries, and also what would be the impact of that for gene environment interaction and gene by cohort interaction. And we thought that it would be really great if we could look at whether there are differences in the effect of genetic risk for cognitive decline across birth cohort, as clearly the environment and the cognitive level of more recent birth cohorts are changing over time. And for my own work, it would be a very useful background piece of work before looking into more specific risk factors or policies such as schooling or education reform. So that's how I ended up stepping aside from the type of work I usually do to try to do this type of observational study, looking at changes in genetic risk for cognitive decline across birth cohorts. So as we were reviewing the literature and getting started on this topic, we looked at the literature on cognitive decline across birth cohort, and it seemed clear that the risk of late life cognitive impairment and incidence of dementia in particular may be influenced by cohort-specific effects, with lower incidence reported in several high-income countries. So as an example, there is this work by Taudorf and colleagues using Danish registry data that was published in 2019 that shows you time trends in total incidence and prevalence of dementia in Denmark up to 2015. And what it's showing is that, of course, prevalence is still increasing, but incidence seems to be decreasing at a rate of about 2% per year in Denmark. And this echoes finding in a number of high-income countries, in France, in the UK, etc. So I should say, of course, that a lot of those trends are up for debate, are really heavily debated. It was really interesting work by Mikko Mirtila and colleagues looking at learning effects, that it might just be, especially in HRS, that respondents seem to be doing better cognitively because they keep taking those tests. There's a question about comparisons across heterogeneous and, in the case of France, for example, not very representative studies, how these trends would translate outside of high-income countries or in younger birth cohorts, especially in the US, that may not have very favorable health profiles. But there is also some literature looking at the drivers of these trends. The first one, which is of particular interest to me, is higher education attainment in younger cohorts, which might have improved their cognitive reserve, health promoting early life environment, some evidence of reduced exposure to infectious diseases, and of course, medical developments for the management of midlife cardiovascular risk factors in recent decades. So that's one piece of the literature that drove our interest in that question of whether there is a change in the genetic risk for cognitive decline across birth cohorts. The second piece of the literature, of course, is genetic risk for cognitive decline itself and the contribution of APOE. So trajectories of cognitive aging, as you know, are characterized by very high individual heterogeneity. And at least some of that heterogeneity is driven by genetic predisposition, and in particular, the E4 allele of the APOE gene is the strongest genetic risk factors for late onset Alzheimer's disease, and also associated more generally, also it's a bit more debated, with cognitive decline. So about 25% of the Caucasian population carries at least one E4 allele. So carrying one of those alleles is associated with a threefold increase of Alzheimer's disease, and a 50-fold increase if you carry both of those alleles. So an important question, and you'll see why when I get into what we were trying to do for us, is if you are carrying the allele 4 of the APOE gene, when does it have an impact on your cognitive decline? Like, is it only in later life, as a lot of the literature seem to have indicated, or can it already have an impact on your cognitive decline quite early on? So there are two very recent or relatively recent piece of research that seem to indicate that there is an impact of carrying the allele 4 of the APOE gene that has an impact on your cognitive decline relatively early on. There was a paper by Zimmerman and colleague published a few months ago using data from the UK Biobank that showed that carrying the allele 4 of the APOE gene was associated with changes in cognition as early as 45 years old or even before. And there was really interesting work from Garbi Meliani and colleagues, also using data from the UK, but looking at the Whitehall study, so with data over time, which looked at global cognitive score over the adult life course as a function of the number of APOE alleles that you are, allele 4 that you are carrying, and the impact that this would have on your standardized global cognitive scores. And as you can see on the graph, especially if you're carrying two of those alleles, you have a lower cognitive function to start with, and sharper decline as well, and that from quite an early age. So that more recent literature was interesting for us because it points at the fact that there might be an impact already quite early on in midlife, not just in later life on cognition. And the third piece of literature that informed our approach and our question are existing gene bioenvironment studies. So what was clear from all the literature that we looked at was that the magnitude of the effect of your APOE carrier status on cognitive function seemed to vary considerably across study, which might be consistent with the potential for gene environment interactions. And indeed, there is quite a large literature which shows that there is some plasticity in this association between APOE carrier status and cognition. For example, there are really cool papers looking at the impact of social environments and specifically neighborhood characteristics that either amplify or reduce the risk of innate genetic vulnerabilities on cognition. I'm thinking here of the work of Jason Boardman using data in Chicago, for example, looking at neighborhood characteristics and cognitive decline. There is another piece of the gene bioenvironment literature that was really very important for us when we were thinking about how to design our paper, which is all that literature, and there are quite a few papers using birth cohorts as broad and hopefully exogenous indicators of change. So using birth cohorts as indicators of social change has been something done in sociology since the 1960s, and it's been used in gene bioenvironment interaction across a number of disciplines in sociology and medical sciences or epidemiology to look at obesogenic environments, genetic risk and obesity. Smoking laws and genetic risk and smoking in demography, sociology, and genetic correlation between education and smoking, for example, across birth cohorts in sociology in this case. And many other papers have also looked at gene by cohort interaction, but to our knowledge, not in relation with cognition and cognitive decline. So that's what we set out to do in our study. So the objective of our paper is to test whether the association between genetic risk as measured by carrying the allele 4 of the APOE gene and cognitive decline has changed over time, so across birth cohorts, which are likely exposed to different environmental factors. So as I mentioned, echoing previous literature, including in gene bioenvironment interaction, we are using birth cohort as a broad indicator of environmental, medical, social changes to examine whether genetic influences on cognition in mid to late adulthood may vary over time. So, as already mentioned, this measure is really interesting because it's exogenous. The hypothesis that we are testing is that individuals who are born later in the 20th century are potentially experiencing an environment that is more protective of their cognition because of advances in educational attainment, medical care, etc., compared to older cohorts. So such difference in social and other exposures might manifest in smaller genetic effects on cognitive function for younger birth cohorts. So that's a social trigger model, I would guess. So that's the hypothesis that we are testing in the paper. So how we do it is that we take advantage of data spanning 4 birth cohorts in the health and retirement study, and we try to replicate all models in the English longitudinal study of aging. So the data that we are using, so first the health and retirement study. So I will go very fast because I think you're very familiar with this study. So I will not introduce it, but just mention how we used it. So we restricted our analytic sample to non-Hispanic white respondents, and this is exclusively for comparability purposes with the English longitudinal study of aging, which has almost exclusively white participants. So we restricted HRS for that reason. Respondents had to be age 50 and older. They needed to have genetic data, born before 1950, and at least one measure of cognitive function over the study period, so between 2000 and 2014. So after a lot of consideration, we decided to use a closed sample in the sense that we are not adding new respondents into our models at different time intervals with the refreshing samples in HRS. For complexity purposes, but also because refresher samples might be too young to already exhibit cognitive decline. We might not have enough follow-up to observe cognitive decline over time with those new entrants. And they also would need to have been genotyped to be eligible for our analytical sample, which may not be the case with the latest refreshments. So that's so a closed sample. We also excluded proxy respondents because specific cognitive performance tests that we are using to calculate a comparative cognitive score across HRS and ELSA cannot be conducted with a proxy respondent. So we exclude these respondents when they start having a proxy. So they can be in our sample until they start having a proxy. And I'll come back to that issue in a second. So this is the flowchart of our analytical sample selection in HRS. So we start with the full sample, apply our exclusion and inclusion criteria, and we end up with analytical sample of 7,422 respondents. Then we decided to try to use in parallel, in combination, the English longitudinal study of aging. So I don't know how familiar you are with this study, but it's a nationally representative cohort of individual age over 50 residing in England, and it's been developed jointly with ELSA, with really significant overlap in the type of questions, measures that they use to facilitate cross-national comparisons. They're part of that of those sister studies of aging. So really, it's a lot of of work has been done to make those studies as comparable as possible. And specifically in ELSA, the sample was drawn from respondents to the health survey for England, who are in the eligible age bracket, so age 50 and over. And enrollment started in 2002, 2003, and with interviews, same model as HRS, with interviews every 2 years through 2016 in our case. And we applied exactly the same analytic inclusion and exclusion criteria as in HRS because they have the same genetic data, etc. So this is the flowchart of our analytical sample. We started with, it's a much smaller study, so about 18,000 participants. And after applying the same criteria, we end up with an analytical sample of about 5,851 respondents. So a very quick note on excluding proxy respondents. So we try to think about what would be the impact of including those proxy respondents on our analysis. So it's very likely that by excluding those respondents, we end up with a much healthier sample cognitively. And so we had a quick look in ELSA. Those who carry the ApoE4 allele are 40% more likely to be a proxy respondent at any time than respondents who do not carry the allele. But what was reassuring to us is that there was no difference across birth cohorts in HRS and ELSA. So it's cognitively healthier, but it is balanced across the different birth cohorts, which was reassuring for the type of estimates we are trying to get at. Yes, Lauren, you have raised your hand.
I had a clarifying question about the ApoE4 allele in both samples, because I noticed in the HRS it looked like some people you just didn't have that allele. And in this study, it looks like that wasn't the case. Did you have to impute the ApoE4 allele in both?
Yes, so the way, sorry, I think I have, if I can jump to the genetic data. Yes, and I'll come back to the rest after. So they've really been, so the teams in HRS and ELSA have been working together. So we used imputed data for ApoE both in HRS and in ELSA. And in HRS, while we were doing the study, directly assessed ApoE data was released. So we redid our analysis on that, but we don't have equivalent data in ELSA. So in ELSA, it's imputed exclusively. We don't have directly assessed. Okay. If that answers your question?
Yes.
Yes.
Thank you.
Okay, perfect. So let me go back a second. Yes, so that's for the presentation of the two data sets. So our key exposure of interest was birth cohorts, and we followed the way it was done by Stephen Walter and colleagues in that paper, looking at the association of genetic risk score with body mass index across different birth cohorts, and they used data from HRS. So we categorized birth year into 4 cohorts to optimize sample sizes. So a cohort born before 1924, 1924 to 1933, 1933 to 44, and 34 to 43 to 49. Sorry. And we had exactly the same for birth cohorts in ELSA as well. And this was to be able to compare with other papers, like this paper from Walter and colleagues, and I'll show you results using slightly different definitions. Cognitive function. So we used 3 tests that were identical in HRS and ELSA. So it's a pity that we cannot use a full battery of tests in either data sets, but these are the 3 that are fully comparable. So we use immediate recall, delayed recall, and orientation to the day of the week, date, month, and year. So the test of immediate and delayed recall comprised 10 common nouns. Participants were asked to recall as many as possible immediately and approximately 5 minutes after. And the procedure was completely identical in the two surveys with the same list of nouns randomly assigned in both cases. Orientation to the day of the week, date, month, and year assessed exactly in the same way in both survey, with 1 point each given for correctly identifying day of the week, date, month, and year. We then combine these three tests into a cognitive function scale, which can range from 0 to 24 possible points. So 10 points for immediate recall, 10 points for delayed recall, and 4 points for orientation, with higher scores indicating higher cognitive function. And we use this scale because it's been validated for use both in HRS and ELSA specifically, but also in previous studies comparing cognitive levels in HRS and in ELSA. So as I mentioned, for the genetic data, the teams in HRS and ELSA have been working very closely together with the team from the UK, going to visit colleagues in Michigan for a few weeks when they were doing the data cleaning, etc. So in HRS, genetic data was available for some respondents who had consented and provided salivary DNA between 2006 and 2010. I mean, you know all this, so genotyping, imputation, etc., has been extensively described elsewhere. And so what we did for our study was to use the imputed value of the two variants that compose the ApoE gene and categorize HRS participants as carrying at least one E4 allele or not. So that's our key genetic exposure. And as I mentioned, as we were working on the paper, direct assessment of the ApoE gene was released, and we redid all our analysis using that data set. So in ELSA, we had genetic data for a subsample of participants who consented and provided blood samples between 2004 and 2008. Samples were analyzed, genotyped at UCL. And again, the two studies were designed to be comparable. So exactly the same quality control procedures were used, except that UCL Genomics excluded SNPs with missing call rates over 5% rather than 2% in HRS. But we had no reason to think that this would impact our work. And we defined ApoE carrier status in the same way in the two studies, so presence or absence of at least one E4 allele. All right, so our methods, now that we have the data, the rationale, how we try to do it. So our statistical approach, we decided to use multi-level growth curve models to compare the association of ApoE carrier status and cognitive decline across birth cohort. So that was my first foray into using those models, which proved to be more complex than we initially anticipated once we tried to account for all the recommendations to try to run gene bioenvironment interactions. So the way it's structured is that the random effects models included 3 levels, so with each repeated observation over time nested within individuals themselves, nested within households. We built our models hierarchically, first looking at the association between carrier status and cognition, adjusted for age and gender, then including birth cohorts, age by cohort interaction, age squared by cohort interactions, and finally, our parameter of interest, which is the interaction between birth cohort and ApoE carrier status. So that's what the parameter we are the most interested in. So as we were discussing the model, I read the paper by Matthew Keller and colleagues who makes a very strong case for fully controlling for potential confounder by entering all covariate by exposure and by environment, and all covariate by your genetic risk factor interaction in your models. So that's what we try to do. We entered all covariate by cohort and all covariate by APOE carrier status in our final model, which made things very complicated, I thought, in terms of the direct interpretation of the models, because you end up with so many interactions that it's really hard to read the results. And in all models, age and age square were centered on scale, because we tried to compare respondents at the same age across the different birth cohorts. So I thought a lot about how to display the model in a way that was easy to read. So I asked my colleague Robert to write the model. So I thought in the end it was the easiest way for you to see how we try to think about that model. So you have our outcome, so our cognitive score, which can range from 0 to 24. You have our random intercepts, both at the individual and at the household level. And you have the random age slopes, both at the individual and household level in our models. And you have a fixed intercepts and a number of fixed effects for age square, gender, APOE carrier status, and our cohorts of interest. Then we try to follow Keder's recommendation and add all those interactions. So, for example, just example of interaction with APOE carrier status. You have an interaction of APOE carrier status with age square, with gender. And finally, the quantity we care about, which is the interaction between our cohort measures and APOE status. So it's those three quantities here. So hopefully this clarifies a bit what we try to do. I would say that the difficulty in presenting that data, but again, it might be my ignorance of those models because it's very different from what I usually do, is that it's hard to report because estimates are not immediately readable. So what I will present to you are graphs depicting trends over time. Yes, Jason, you had a question.
I think I have one pure clarification and one question that you might wait until later. The pure clarification is about whether the cognitive score is normally distributed in your data.
Yes, we assume that it is. Yes. Yeah.
But if you graph the histogram of your 0 to 24 count, it looks normal. I would have guessed that it was like highly skewed, that no one gets a 0 essentially.
That's a good point, actually. That's a strong assumption that we are making. Yeah, that's correct.
And the one you might want to
might
want to wait on is about the Keller point about confounders. So it sounds like the confounders that you're focusing on, are they just age and gender?
Yes. So here we have age and gender. Yeah, that's right. For the covariates. Yes. Yeah.
So it's not clear what confounders, what you mean by confounders here, right?
Okay.
So maybe I'll take that up later.
Okay, that sounds good. Yeah, I mean, because I thought that, that's a good point. I think we thought that we had to interact both the environment exposure with all the covariates that were in the model. That's how you would take into account the confounding. But yeah, maybe you have suggestions about that and we can come back to that. Yes, Eva, you have a question.
Hi, and you may answer this, but since we're talking about it already, have you considered education and practice effects for cognition when adjusting for those? Maybe you did sensitivity analyses later, but I think
yes,
those are probably key to include right away. I don't know if you did those, but yeah.
No, we didn't, and that's one of the questions I actually had for you, whether that's something we should be looking at in additional sensitivity analysis.
Okay.
Yeah, that's a great point, and yeah, I mean, it's great to already know that you're thinking of that. So perfect. Okay. Great. So a few additional features of the model. of course, when it comes to we try to disentangle age from cohort effects. So I'm not sure we're succeeding, but at least what we are aware that the differential age distribution by birth cohort will impact the accuracy of the cohort difference estimate that we're trying to get at. So to try to enable the comparison of the same age across different birth cohorts, we scaled and mean-centered age, both in HRS and in ELSA. And we report the joint wall test for the interaction between birth cohort and APOE status. So that's how we try to, one of the ways we try to get at this issue of disentangling age from cohort effects. So, and in this test, a p-value that is significant indicates a significant difference in the effect of carrying the APOE E4 allele on cognitive decline across birth cohorts. Another thing we try to account for is mortality selection, which has been highlighted as a potential issue in gene by cohort interaction studies, including in this article published in 2017. Because of course, participants who are older would have to have survived until the genetic data was collected to be included in our analysis. So as recommended by that paper and a few other papers, actually, we used inverse probability weighting to give more weights to respondents with a lower propensity of providing genetic data. And we did that by fitting a logistic regression model with inclusion in the genetic sample as the outcome and age, whether foreign born, gender, education, marital status, income, and wealth as the dependent variables. And the predicted probability of providing genetic data from these models were used as weights in all the analysis that I'm going to show you. And we did that both in HRS and in ELSA to try to get to this issue of mortality selection. Then we did a number of sensitivity analyses, so not yet taking into account education and learning effects, but so we dealt with missing data based on the recommendation by Jordan Weiss, with a co-author on this paper. We imputed missing data using a non-parametric approach using Miss Forest in R. So that's for missing data. To try to take into account the semi-competing risk of death in additional analysis, we add to our model an indicator for death at each wave, and also a variable indicating the number of waves missing, to our main models, both in HRS and in ELSA, to account for that issue. We talked a lot with Erin about confounding by genetic ancestry, and her advice was to add to our final models, to sensitivity analysis, the first 10 principal components for the Alzheimer's disease polygenic score without APOE. And we followed the approach proposed by Dalton Conley and colleagues in 2016, by regressing the polygenic score on the 10 principal components, take the residuals, standardize them, and add them as covariates to our models. So that's how we try to take that into account. But any suggestion or better ways to do that would be very welcome. And finally, two other sensitivity analysis actually. So we had a direct assessment of APOE, so we replicated our main model in HRS using that data. And then we thought about alternative specification of cohort and age effects. And we tried to do that in two ways, to incorporate birth cohort as a linear term in our models with splines. And same for age, instead of age categories, age as a linear term with age square. We included age as a linear term with splines at age 60 and 80 to account for the plateauing of cognitive function around age 60 and steeper decline in older age, as reported in the literature. We're not completely convinced about that approach. I think there are maybe other ways that we could be doing to try to think of different ways of including cohort and age effects in our models. So again, suggestions would be very welcome if you have some. So we're posting what we're doing as we go in for replication purposes. So Robert Greener posted everything, all our files and scripts already on Zenodo if that's of interest to you. All right, so our results. So first off, our descriptive statistics. So this is showing you a number of descriptive statistics by survey. So looking at the health and retirement study and the English longitudinal study of aging, and by birth cohort. So we have our 4 birth cohort, mean age at the first cognitive measure, average age across the cognitive measures, the number of cognitive measures that we have, and the proportion of males, and finally the proportion carrying the allele 4 of the APOE gene, which was stable across the different, which was very similar across the different birth cohorts that we had, both in HRS and in ELSA. And you also have the sample sizes for each birth cohort in both studies. So we have decent sample sizes. It's a bit small in ELSA for the oldest birth cohort, and you will see we have very wide confidence intervals in all our models, likely because of that in ELSA for that oldest birth cohort. All right, so other descriptive data, which we thought was quite informative. We looked at the mean cognitive score, and so adjusted for gender and stratified by survey. So you have HRS here, the English longitudinal study of aging, the different birth cohorts, and then you have it by age groups. So as you would expect, the average cognitive scores declined with age in both samples. But when you look at cohort effects, it's quite different between HRS and ELSA, and that's something we are struggling to understand. So if you have a look, for example, at respondents who are 76 to 80, as you can see, the oldest birth cohort, I mean, there is no clear difference between the oldest birth cohort and the subsequent birth cohort in the average cognitive score. But if you look at the same age in ELSA, cognitive function was consistently higher in the youngest birth cohort compared to the oldest one. Yes, Eva, you have a question.
This is just a quick clarification question. Can you remind us what the range of this cognitive score is and what a point difference means?
It's 0 to 24, the range of
0 to 24, and this was the composite one that had the 3 different measures combined yes. into it. Okay.
Yeah, thanks. Yeah. So immediate recall, delayed recall, and locating in time. Yeah.
Okay, thank you.
Yeah, so you're right that we didn't do that, but so you'll see all the effect sizes we are reporting are actually very small, and we have not done that, but we should think about it, how to locate those estimates in the broader literature looking at cognitive effects. But it's a bit harder because we are using this composite score, which a few comparative studies are using, but not so many studies are using. So locating our effect sizes, it is a bit harder, but we should look into that. So so with age, cognitive score decline, but different patterns across birth cohort in HRS and ELSA. Then we looked a bit as a sanity check, I guess, at the association between carrying the allele 4 of the APOE gene with cognitive function and age-related cognitive decline. So if you are carrier, you have a lower cognitive function score, both in HRS and in ELSA, and the estimates are very similar. And also, and also you have a steeper cognitive decline if you are carrying the APOE allele 4, both in HRS and ELSA, which again is in line with the literature. So it was comforting that we can confirm that in our sample before going into the models across birth cohorts. So this is the first graph I wanted to show you based on our multi-level growth curve model. So it's showing you separately for the health and retirement study and for the English longitudinal study of aging at the bottom, age-related cognitive decline with age on the x-axis and your predicted 24-point cognitive score on the y-axis. So just so it was a bit more visible, I've zoomed in a little bit so you could see better the lines, because we present those cognitive decline by birth cohort. So for the first birth cohort that we have. So if I can start with English longitudinal study of aging, I think two things were striking to me. The first is that we have limited overlap in terms of age across the different birth cohorts, which is obviously an issue for our purposes. So that's something to keep in mind. And the pattern across birth cohorts is very clear and echoes what we found in our descriptive statistics at the same age. For example, at 80, younger birth cohorts have better cognitive function than older birth cohorts. The picture in HRS is similar and different. It's similar because we have also limited overlap, as we knew, in terms of age across birth cohort, but the pattern across birth cohort at the same age is very different. And you have this older birth cohort, so those who are born before 1924, who have a higher cognitive score at age 80 than subsequent birth cohort, with the youngest birth cohort having a slightly different trajectory as far as we can tell. So I think it goes to Eva's point already about integrating education and learning effects in those results. But I don't know why it would impact HRS and not ELSA, like those learning effects and education. I mean, there is no reason why it wouldn't be an issue in or something to take into account, at least in ELSA as well as in HRS. So that's a bit of a puzzle for us and something we would love your your comments on when we get to the discussion. So the core of our results are those predicted cognitive decline trajectories, but by birth cohorts and by APOE status. And this is how they look like. So again, separately for the health and retirement study and for the English longitudinal study of aging. As before, on the y-axis, you have age. On the x-axis, sorry, you have age. And on the y-axis, our predicted 24-point cognitive score. We then looked at each different birth cohort, and we separated those curves by yes carrying the E4 allele of the APOE gene versus no. Sorry, I just saw that I cropped the legend when I pasted the graph. So what we found in those analyses is that birth cohort does modify the association between APOE E4 carrier status and cognition. The joint wall test was significant in both samples. We also find that the youngest birth cohort, for example, so the birth cohort born here in HRS between 1994 and between 1944 and 1949, has less of a difference in cognitive function by APOE status to start with. So the two lines are closer together, and the same in ELSA. And when we consider data over time, for example, if you look in HRS for respondents in the third birth cohort, they have a difference at age 80 in their predictive cognitive score by APOE carrier status, which is also present in ELSA. But there is no difference at the age we observe, at least in the youngest birth cohort, by APOE status in your cognitive level or cognitive decline in the youngest birth cohort. So that's a key difference that you see across birth cohort in HRS, to a certain extent in ELSA as well, with the exception of that oldest birth cohort. But as you can see, the confidence intervals are very wide and we have a smaller sample. However, that being said, the key issue that we have is that I already mentioned is a limited overlap in age. So, sorry. So for 1934 to 43, we follow them up to age 80. We don't have that data in the youngest birth cohort. So it might be that those curves would separate later on as those specific respondents are aging. So for those youngest birth cohort in the two study, we tried out of sample predictions to have a look at how, based on our models, those curves would continue to evolve as those people are aging. And we do not find differences in cognitive decline by ApoE carrier status as those people age to be 80 or 90 in that younger birth cohort. And this is how it looks like in ELSA. I'm not including it for HRS because as I was preparing the slide, I found a little mistake, but the trend is the same. So same graph as before, except that now we have in the dotted line is our out of sample prediction. And as you can see, for the youngest birth cohort, we find no significant difference in cognitive decline between carrying or not carrying the ApoE if the allele E4 of the ApoE gene. So we did, as I mentioned, a number of sensitivity analysis. The first one is adjusting for the competing risk of death. We did that in both study, and we didn't find any significant differences in our results. Same when we adjusted for confounding by genetic ancestry, the results remained almost identical to our main models. And when we rerun our model in the HRS dataset that had been released with directly assessed ApoE data, we also did not find any differences in our results across birth cohorts. So this is where it gets a little bit messy, and I apologize for those graphs, but we tried a number of alternative specification of age and cohort effects. So one that we are presenting here is incorporating birth cohort as a linear term with splines, and age also as a linear term with splines at ages 60 and 80. And as you can see, so in a way, it's aligned with our main results, but I don't know how much we can really make of those results. So I'm just presenting them to you, knowing that these look really weird, especially for the youngest birth cohort, where you seem to have an increase in cognitive function with age, which is likely not quite right. So we are just thinking of ways of doing that better. And as I mentioned, if you have any suggestions about how we could improve that, we would be very keen on hearing your suggestions. All right, so discussion and future work. So overview of the results. So ApoE E4 carrying that allele is associated with lower cognitive function, steeper cognitive decline in older birth cohorts in the US. But in terms of cognitive decline, it is less the case in respondents who are born in the youngest birth cohort. Our results were, to a certain extent, robust to adjusting for semi-competing risk of death, selection into the genetic sample, but I think that's a bit of a stretch what I wrote here, different specification of age and cohort effects. We have definitely more work to do on that front. I think a key strength is that we really tried hard to replicate those findings in HRS in an independent sample of English older adults that is very directly comparable. And from what we can see at this stage, those core differences in ApoE carrier status, related cognitive decline are not completely explained by age differences across the cohort that we consider, but a full demonstration of those differences would require further observation time on younger cohorts. And I wanted to summarize how I felt about this paper. Like, I think it was a really nice idea at the beginning. And as we were progressing through our models, and I think me at least understanding better the complexity, but also the limitations of the data that we had, I think we end up with something that is a lot more simplistic than what we would have wanted. I guess one could argue that it's the case with a lot of research projects, but I felt with this one in particular, it's very interesting and yeah, very stimulating learning process. But I think yeah, we still have more work to do to have something a bit more convincing. Potential contributions. I think we're adding to very well documented birth score differences in cognitive function. So there is some work showing that the duration of preclinical and mild dementia is shorter among younger birth cohorts, and in a more from a more biological perspective, it looks like the burden of amyloid accumulation is lower in individuals from recent birth cohorts. So, you know, if they stand, those results would add to that literature. So then what it means for gene-environment interaction. So it might be that changes in the environment that those successive birth cohorts have experienced might mitigate some of the negative impact of genetic risk on cognitive decline in younger birth cohorts. So, however, the experience of birth cohorts do differ between the UK and the US. So it is meaningful in a way that our findings in the US are kind of replicated in a comparable sample in the UK. But it also comes back to my initial question that how do we explain that we find a similar pattern in terms of the gene by cohort interaction, despite a different pattern in cognitive function across birth cohort in the two countries? That's really something I'm not completely sure about, to be entirely honest. So we're still thinking about. This is also adding to a large literature on the changing genetic penetrance across birth cohort on a number of phenotypes and health behavior. So I've already mentioned quite a bit of that literature in the introduction, but there has been research looking at height, BMI, heart disease, and smoking, and we just wanted to add a study looking at cognition and cognitive decline to that literature. And of course, the question being whether the reduction in the impact of whether what we see is a reduction in the impact of latent genetic risk for cognitive decline in those younger cohorts which are aging in relatively healthier social environments. So that's what that would show, again, if those results stand. I think more broadly, it really shows the importance of the environment in shaping cognitive trajectories over the life course, as well as their genetic determinants. Those birth cohorts are really interesting and very comprehensive proxy for historical and social changes. Educational attainment, access to healthcare, health behaviors, etc. It's been shown repeatedly in the sociology or demography literature that they are uniquely tied together within birth cohort, and that's what we are trying to get at. And hopefully there are exogenous measures as individuals cannot self-select into birth year, so that helps with the measure of the environment for gene by environment interactions. But again, as a limitation with this approach, I think frustration is that we cannot pinpoint specific elements of the environment that would account for the cohort differences that we observe. So if those results are standing, why is it that there are differences over time? Like, is it education? Is it access to midlife treatment of risk factors for cognition? Likely a mix of all that, but being able to quantify that and measure that is, I think, something that should be the focus of more work. Strengths and limitations. So we limited our analysis to non-Hispanic white respondents for comparability purposes, as I mentioned. So it's imperative to extend those analyses to other groups as more data become available. or replicate the work we have in HRS with another data set in the US that would be comparable and for which we have a more diverse sample. There is a potential misspecification of age versus cohort effect. So we do try to compare birth cohorts around the same age. But as I mentioned, we have only partial overlap in age groups across birth cohort, and we had to rely on out of sample predictions to look at younger cohort at later ages, which is of course a big limitation of what we're trying to do. So we cannot stretch the data more than we have already, I think. So that's just a limitation, I guess, of what we try to do. But it's a question of whether, we should be humble in the way we are reporting those results, of course, or whether, we just did that a few years too early and we should just put it aside for a while and redo it in a few years when the participants of both studies will have aged a bit more. Another point for me is that it's unclear how this association might hold for younger cohorts in the US, especially if they exhibit a poorer health profiles than older generations at the same age. So how will it look like in the future is not very clear. A few strengths is that is HRS data. It's a large sample of older Americans with repeated standardized cognitive measures, replication in ELSA, very comparable data set, so that helped. And we tried hard to account for a number of identified sources of bias in gene bioenvironment studies, endogenous environment, selection into the genetic sample, semi-competing with off-desk, interaction terms across covariates, etc. So we tried to account for those sources of bias, but I'm sure more can be done, and it would be great to have your thoughts. So just very briefly about where we are heading next. So I think for me, it's clearly to go back to quasi-experimental and experimental work and integrate better sociogenomics into these approaches. And I'm really very excited to meet with some of you afterwards to have a chat. So specifically what I'm planning is to try to look at specific reforms that could feed into the trends by cohort that we are portraying in this paper. So with Patrick Turley, we're working on a gene bioenvironment interaction in the UK Biobank using the English Welsh compulsory schooling law and looking at depression and precognition as well. So that's work that we have just started. And the next one is, I think, a plug for the Irish longitudinal study of aging, TILDA, which is a really cool study, which has beautiful genetic and epigenetic data, and they are really nice people to work with as well. And Ireland went through many interesting schooling and education reform, including one in the 60s that greatly expanded access to secondary education. They made secondary education free for everyone very suddenly. And the goal here is to look at the impact of that reform on depression and cognition and use that genetic data to look at gene bioenvironment interactions. So you're returning to my to my original line of work. And I think that's it. Thank you so much for listening. I think I stayed more or less on time, and I'm looking forward to your questions. As I mentioned, this is very much work in progress. So any comments or advice you have for us would be very gladly received. Thank you. Should I stop sharing? Maybe it's easier for the discussion. Yeah.
Let's try that. We might be referring to some of your figures, so who knows? But I think there'll be a lot of questions. If we could just queue up with the raise hand feature, we'll go in order of questions that way.
Yeah.
Hugh, if you could go first.
Yes. Thank you for the talk. So this might be just some details I missed from your presentation, but the first question is, so how did you actually quantify, for example, the ApoE effect on the cognitive decline instead of cognitive level? I think you showed some results there. I wonder how you parameterize this effect size on the slope. And the second question is, I think you talked about, for example, how you use the principal components to adjust for ancestral confounding polygen risk scores. So clearly those scores were used in the analysis, but somehow I missed the result on the effect of polygen risk score on cognition level or cognitive decline. I wonder if you actually tested those and what were the conclusions?
Thank you very much. So to get to your second question first, no, we didn't. So your advice would be to look at the effect of the polygenic score for Alzheimer's disease without ApoE on cognition. Did I understand?
I wouldn't say it's an advice, but I wonder what you used, what you tested with those scores. So sounds like it's just another covariate in the model. Then you didn't directly assess the impact of cognitive effect. Okay.
Yes, that's correct. So the way we did it was just in the sensitivity analysis. We adjusted for the 10 principal components. Yeah, and that's it. We did not use it more than that in our model. So very much sensitivity analysis, not doing much more with that. Yeah. Then for how we look at the effect of carrying the ADN4 ApoE gene on cognitive decline and just not cognitive level, right? Is your first question. How we parameterize the slope? That's a good question. So if I can go back to the model, sorry, so I'm just going to share again my slides and go back. Sorry. So it's an interaction term here. So we parameterize it as an interaction term between carrying the ApoE allele and age and H square. Is that answering your question?
So when you show, for example, a significant effect of ApoE on cognitive decline, are you testing whether beta 5 and beta 6 being 0? So you would so the null hypothesis would be both of them being 0.
I think so, right? I think so. Yes. So I would, to be honest with you, I would need to double check with the statistician who would help us on that to clarify that. But I think that's correct. Yes. Yeah.
Okay. So a quick follow up would be that. So is this based on, because I'm not familiar with ELSA, but HRS actually has longitudinal cognitive measure, right? That's what I'm assuming that's what the trajectory is trying to show.
Yes. Yeah.
So is there anything that's accounting for repeated measures of the same individual?
Yes. So we have 3 levels with repeated measures nested within individuals, themselves nested within households. So that's the way we built it with standard errors then clustered at the household level, I think. Yeah.
I see. Yeah. Thank you.
Yeah, of course.
Yeah. Hi. I'm Corinne Engelman. I might the very last figure, I think it is, where you mentioned that you were kind of perplexed about the cognitive function increasing with age.
Yes. Yeah.
And I think, so Eva already mentioned this. I think what might be going on is the practice effects, but so let me just look at, I mean, it's possible that those individuals are still pretty young and not really, showing true cognitive decline. And that when you, when they take the test multiple times, they actually improve. So we've seen that in our studies. I don't know if that's what you're seeing there, but it would definitely be worth doing what Ava suggested and putting practice effects in your model to see if that deals with that or resolves that issue.
Yeah, no, I think that's a great point that you're both making and something we've been thinking about. I think what why we haven't done it yet is why do we have a different pattern? So why wouldn't we have practice effects in the English, in ELSA as well as in HRS? But you're right, we didn't look at those graphs which might be showing that here actually. So I think it's a good incentive for us to do that. We were mainly looking at the graph across birth cohorts, thinking, you know, if it's practice effects, why don't we see it in ELSA across the different birth cohorts as well? But you're right. I think we've postponed it for too long. We need to do it now. Yeah.
Yeah. I think if they truly are experiencing decline, if they're old enough or something, or for whatever reason, you know, the practice effects won't be enough to, I mean, they'll still be experiencing decline. Whereas if they're not experiencing any decline, and then you add in practice effects, their cognition will improve. So how far apart were the cognitive testing visits?
In ELSA?
Yeah, or either of them. Yeah.
Every 2 years. Every
2 years. Okay.
Yeah.
Okay. Well, I mean, it's worth just trying it and seeing if that resolves the issue.
Yeah. No, I think that's a great point. It's good you gave us the motivation to do that.
Yeah. Okay. Great.
Ava, go ahead.
Hi there. Just a quick, I actually have 2 points. Did you include random slope for age as well in your models? I didn't catch that as you were. I know you included random intercepts for person and household.
We also have random slopes. Yes, at age, at the individual and household level.
Sure. Oh yeah, that's right. I guess I'm curious about the random slope at the household level. I understand it for the individual level, but that's not my question. I actually wanted to talk more about the difference of the effects across cohorts. So this is a question for you and actually the rest of the group, because I'm working on some similar stuff, not across cohorts, but definitely across time, and looking at cognitive trajectory differences by genetics, and when do we start to see those differences? And I mean, I think within our cohort, at least, we weren't able to observe some of these differences by genetics. Was it, I don't know, Corinne, a few years ago? And then now we're just starting to see some really strong associations. And so I mean, I'm still trying to understand, obviously there's an age difference in a little more data collection, but it's not so much that our sample was so young that you shouldn't have been able to see an association earlier on. But that's something that I'm wondering what your thoughts are on, just because right now you don't have those overlapping ages. And it seems like that with older cohorts, there is a stronger effect. You know, you do see this stronger effect the older the cohort, which I don't necessarily know that should be the case, you know, that it should be linear like that as you have an older cohort, you should have that pattern. You might see differences across cohorts, but why would it be incrementally so? And so this is not necessarily, this is more of a musing question for everybody here, to think about reasons why we should see this particular pattern of you know, associations that change by cohort. And yeah, I don't know. Sorry, that wasn't a question, but it's more of I'm trying to understand the data as well.
So yeah, I wish I had an answer. I don't really know. But can you just tell me more about your cohort? I'm very curious now about that finding. So what type of data are you using? And
sure.
Sorry, go ahead.
No, oh sure. It's the Wisconsin Registry for Alzheimer's Prevention, and it's a relatively small sample compared to what you're dealing with. So we have, you know, just under 1,500 individuals. Also longitudinal assessments every 2 years. We have a lot of different cognitive measures. It's not a population representative sample, but these individuals are, it's considered a preclinical cohort. So we have the age range is, I mean, earliest is 40, but really it's more like 50s to, 70 and beyond. And so we have about, I don't know, it's getting up to almost 20 years of data collection, for an individual over time. And so I've been looking at some of the differences in cognition by genetics. Yeah. So anyway, that's our.
And you see a stronger association between their genetic risk factors and cognition as they had like 60, 80 now.
Right. So when we did the associations, I think a few years ago, or at least someone else looked at interactions between ApoE and age, just simply that. There were, in different kinds of specifications, this was maybe in 2017 or 18, the associations weren't there. And then I just looked at the data again, obviously with the newer cohort from 20, like with a slightly more measures. I mean, it's just a few years. They come in every 2 years, approximately. We see associations, and we see strong differences across age. Yeah.
But I think, from what I understand, that it's consistent with those relatively recent paper using UK data, so the UK Biobank, but also the Whitehall study, which has really great data over time, and I think that's what they show. Maybe differently from what you're showing, that the association gets stronger as people age. And
not that it gets stronger, but the point that I wanted to make was, and I've read those papers too, was just that with it's more about the data collection and data availability and how that impacts the association rather than comparing the different studies. And so that's something that I'm curious about. What are the factors that influence this association specifically? And why did we not see it a couple of years ago, but now we're seeing it, even though I don't think there's a huge difference in the, but maybe there is, maybe, yeah. So anyway, thank you. I've spoken long enough.
Mute myself. Yeah, thank you, Emilie. That was really, really interesting and such careful work. I really liked how you incorporate everything, that all the critiques that people have had so far in terms of policies, with the like IPW estimator and everything. So I really appreciated that. Yeah, as one thing I was thinking of is, as I was looking at this, is it would be interesting to dig into mechanisms a little bit more.
Yeah.
And I was thinking one potential strategy, either to look more into mechanisms or also as just another overall strategy, would be to introduce some matching techniques. So matching people that had similar lifestyle behaviors, I'm thinking of, drinking, obesity, but then also occupational status, education, and then maybe matching, so creating kind of stronger comparison groups in a way. And then one could redo these plots for those comparison groups and then even zoom in on the age ranges where you can actually compare across cohorts. So looking at differences in carrying the ApoE allele between people who are, white collar, looking at differences between people who are drinkers, looking at, so kind of seeing what might have been some of the motivating factors across these different cohorts. I think that would be super interesting. I think one thing that is always too kind of debated is how exogenous really is cohort. And I think that's something that is up for, just discussion, really. I think some people might say it's not very exogenous at all. Some people might say it's more exogenous than obviously, self-reported education or something like that. But I guess that's my other question, is your thoughts on that?
Yeah, that's a good point. We got mixed feedback when I say that cohort is exogenous. So I totally take your point, and I think it's good to be cautious about how I talk about that. So I take that point on board, and I really like the idea of using match comparison groups across a number of characteristics. So thinking of if going back to the potential explanation that we have for the drivers of the difference in dementia incidence, for example, the key drivers, we can try to proxy that with education, employment status as your or occupational category as you are mentioning. That sounds really cool. Yeah, definitely something, maybe not for this paper, but that we should think of, because otherwise it's very I don't know, it gets very dry, right? That you see those trends and then you're left with okay, so why, how, etc. So that's a very good point, and
Yeah,
potentially a really good way of doing that. I agree.
Yeah, it keys up your next paper. Yeah, no.
Thank you. Although, like, I kind of promised myself not necessarily to continue in that specific direction of looking at core differences, because I initially thought, oh, that would be a nice, relatively easy paper, right? They are like because I felt like we were really building on a number of existing papers, and it was so nicely laid out by recent papers what you should and shouldn't be doing in gene environment interaction. And with for me, there was a dream team. Those colleagues and Corsa were just great. We're gonna do it. It's gonna be fine. And well, of course, as always, it was a lot more complicated than I anticipated, at least. So yeah.
No, I feel your pain. I feel your pain. Yeah.
Thank you.
Yeah.
I just to echo Lauren's points of very careful work. I think you're very transparent, about, and it's a really interesting question. That the last figure that you showed up, I don't think you need to show it because you've for my question, but essentially the complete reversal of the trends by cohort, or the levels of cognition by cohort across the US versus UK, where when I see it, I see UK is doing exactly what you think, which is the younger cohorts look higher on cognition, and then the US is the reversal. And that's a real it seems like an open question about even how to go about your cohort analysis if essentially like that first figure isn't behaving in the way that you were expecting. What's your, what do you think's going on there?
Well, that's a key question for this paper, and I honestly don't know, because to be honest, when I saw that figure, I thought, okay, we are overfitting something in the model. Like there is something wrong. There is a parameter not behaving the way it should be behaving, and I just don't understand growth curve modeling well enough, and there is something wrong. But then it's exactly the same trend in our descriptive statistics. That's what we see when we just look at the data without imposing all that more sophisticated modeling on it. So I think it's an actual difference between at that level between the UK and the US. So my key guess is learning effects in HRS, which have been documented. So I think that's a great point. I just cannot get my head around why English respondents would not have the same learning effects over time, and this I'm struggling to understand why that's the case. So yeah, to be honest, we don't really know. We've had many calls trying to decide why. I mean, to determine why that would be the case. It's not a glitch in the analysis as far as we can see, but what it is exactly is not clear. And it's not. So there are a few papers looking at cognitive decline, age-related cognitive decline across birth cohort in HRS. But using more recent birth cohorts, and it's not incompatible with our finding, in the sense that they do find that the youngest birth cohort, which we don't include in our analysis, seem to have a poor health profile in general. So that is not completely out of line with what they find, but still not explaining the country difference, and being a big issue for the type of gene by cohort interaction we're getting at, because is it a clue towards different environments that would have then a different impact both on the interactions between your genetic risk and cognition? And if that's the case, why do we still see something in the same direction when we try to model that? I hope we find a good answer. Yeah.
I mean, the things on the list, which I think, are on the same list that you've been thinking about, are different patterns of mortality selection, which you think about in your paper, right? It could be that the survivors in the US show high cognition because of just a much different mortality selection, or much and so that's one thing. It could be that the point it raises the question of whether your intuition of cohorts getting better over time is true, which is to say, right? So it seems like it's true in the UK, but it's not. But one interpretation, and it's not true in the US. And to me, if you settled on that last one, this like the question would then be like, what's it mean to replicate findings across two countries where the cohort is essentially opposite patterns. So those are, I mean, so that could suggest, on one hand, one of the key strengths of the paper is this analysis, this cross-country analysis, but maybe not really saying it's a replication. It's just more of a cross-country
comparative study. Yeah, that's a good point. Yeah. Yeah, it's a comparative study, not a replication. I think you're right. Yes.
Well, I mean, I think you probably started it as a replication, and then it turns out the data suggests they might not. Might not be a situation where replication is the answer. But so finally on this list, I'm wondering in the model. So in demography, there's this messy issue of age, period, and cohort all having effects on the outcome. What's your period controls?
That's a good point. Yeah, I think we got so focused on the age versus cohort disentanglings that the period part we not really accounting for, right? Yeah, that's a good point.
That's my sense. I mean, I think thinking about that, I mean, I don't know how this goes with the actual patterns of findings, but if there were period effects in old age that differ across these cohorts, essentially like pollution getting better or worse or something, that would be affecting, at the period level, different groups of these individuals. It'd be something to at least consider. I don't have any sense of it if it actually fits any of the patterns, but it did strike me that it's just like in the error term here, it seems like the actual potential period effects of cognition and whether they're strong. So I'll stop there because Ava has, I think, a follow-up.
Well, yeah, I have a follow-up to what you just brought up, Jason, and I have a separate question as well. But my understanding, and I don't know what you were suggesting there, Jason, like when you have age, period, and cohort, you can't include all three in a model. That you only you can account for two of them, but you can't really resolve the differences. So what were you suggesting when looking at period effects?
Well, it's just this interpretation of what I think you're restating the problem correctly, Ava, that it's a either intractable or at least difficult question of separating them fully. But I think maybe my point is we know that the three of them might affect the outcome here. And so what's happening with the period effects in the analysis whether
yeah, so I mean, that's just what I wanted to clarify. So maybe it would be in doing both a cohort and age model and then a period and age model and seeing, I don't know, but this is more my curiosity of thinking about how to approach that and seeing if you see the same trends. But I did have a question actually, and this is also, I mean, selfishly, it's also for me too. The Keller approach, where you just interact everything in the model. Yeah. I'm lucky enough that I can list it as a limitation because the sample size isn't big enough to include that many interactions.
Very nice. Yeah.
But I'm a graduate student. I'm still learning a lot about all this stuff.
Same here.
Yeah. And I'm thinking about, I mean, my approach has generally been parsimony, where interpretability of the model has been important, include the main covariates, but not necessarily interact them unless there maybe has been some interaction reported in the literature already on, that's important. And so this is, I guess, a question to the group and to you to think about, like, well, why did you choose the Keller approach as opposed to just, interacting what you thought was important? And I don't know if anybody else, so obviously to you first, but then I don't know if anybody else has any additional comments on a fully interacted model versus just focused.
So I know this
you
is a
unmuted
this is a
yourself, so yes, go ahead.
well, I just I'm looking at the time, and since Ava and Lauren have individual meetings, I think what we'd like to do, with apologies to the rest of the group, because we're all on the edge of our seat because you're going to solve this intractable problem in front of us. that we'll just postpone this question for the individual meetings.
Sounds
And
great.
thank you very much for your presentation. Give you a couple minutes break, and then I think you're coming back and talking with Lauren.
Thank
next.
you so much for
thank you very
having me,
much
and
for
great
that.
suggestions. I really appreciate it. Thank you so much.